Thank you all for joining this breakout session today. My name is Juliana DePietro. I use she and her pronouns, and I am Central City Concern's Overdose Prevention Program Manager. I come to this work and this presentation with just about a decade in experience in direct service, supervision, academic, government, local social service providers of work really around supporting people who use drugs and primarily through a harm reduction lens. Today I'm going to just give a brief overview of harm reduction in general and how harm reduction interventions intersect with working with youth. I will be discussing some difficult topics, and so I really just encourage folks to take care of yourselves as you need. We will be talking about overdose today and reviewing some population health data that may feel personal to folks in this room. I also really intend for this to promote dialogue. We'll have some time at the end for questions, and I recognize a lot of expertise in this room, and so I want to encourage folks as we have time to just talk rather than just asking questions to me, because I'll be doing a lot of the talking. So anything before I get started? Okay. So just a brief agenda review. I'll be sharing my definition of harm reduction with you all to ground us in this topic. I'll talk a bit about some evidence-based harm reduction interventions that some of which are becoming more and more prominent in the United States, some of which are just starting to emerge here but are evidence-based in other parts of the world. I'll talk about some challenges for youth in accessing harm reduction interventions, review some population health data, as I mentioned. And I'll talk about some youth-specific harm reduction interventions that are really exciting and some lessons learned from those and from some of the preliminary research around harm reduction in youth. So first, to ground us, when I talk about harm reduction, what I mean is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. Harm reduction is also a movement for social justice, built on a belief in and a respect for the rights of people who use drugs. This is a definition directly from the National Harm Reduction Coalition, which I absolutely love. And I just want to address that, and I think maybe our panelists mentioned it this morning, but there's a common misconception that there is a conflict between harm reduction and abstinence-based modalities. In fact, in this definition and in mine that I hold, they're part of the same continuum because arguably the least harmful way to use drugs is to not use them at all. So really harm reduction encompasses a philosophy, interventions and strategies, and really a way of acknowledging that people use and figuring out how best to serve those people in their use so that they have as many options as possible on their use journey. Harm reduction strategies, as I mentioned, do include abstinence-based treatment modalities. Other evidence-based approaches can include medication to support recovery, thinking about buprenorphine, Suboxone, methadone, and other medications, Wellbutrin, syringe service programs, and supplies for safer use, which can often be an entry point to have conversations with people who use drugs as they engage with the supplies that they need to use them. Outreach to serve people where they use, either to deliver those safer use supplies, to do community-based testing, to have conversations, refer people to treatment, recognizing that for various reasons, people who use drugs may not be as engaged with traditional models of care, clinic-based care, or feel comfortable engaging in those spaces. Supervised consumption sites, which are very, very limited in this country, but we do have modalities in New York, which are really exciting, as well as a lot of different countries in Europe and in Australia. These are safe spaces for people to use out of the purview of the criminal legal system. They are often staffed by people with deep medical training and or other folks who use and have deep expertise in using to keep people who use safe from fatal overdose. And then also thinking about HIV and hepatitis C testing, and then transmission mitigation education, because we know the rates of HIV and hepatitis C transmission can really increase when people share certain items for using drugs, and particularly syringes, but also some preliminary data around sharing pipes as well. And I really want to emphasize that any harm reduction strategy, whether on this list or not, they're all going to be grounded in non-judgmental engagement and relationship building. I think another common misconception about harm reduction is that it's just giving people supplies and letting them go. And really, any harm reduction intervention that we want to see is a conversation. So those supplies, handing out naloxone, handing out safer use supplies, should also come with the questions: how are you doing? What does your drug use look like these days? How can I support you in managing that drug use? Maybe making it a little less chaotic, safer for you, safer for the community. A lot of those conversations take a long time, and harm reduction interventions don't often show what we typically look at as success, right? Cessation of use, even reduction in use for some time, until relationship and trust can be built with that person, with that provider. And I just really thinking about creating safe spaces for folks, so that they have the full spectrum of options available to them and can make grounded choices with all the information they need about accessing services, up to and including withdrawal management and abstinence-based treatment as well. So some challenges for our youth population. I recognize there are likely a lot of youth experts in the room, so this is not news to anybody. But ACEs, for youth that create a lot of trauma, particularly thinking about violence and drug use in the home, creates exposure to drugs, also can really create some need for initiation of drug use as a coping strategy for youth. Exposure to community violence, which I think when youth are surveyed, some of the research that I looked into, or youth surveyed in Canada in particular, demonstrated that exposure to community violence in their neighborhoods was a really big factor in the way that they approach drug use and their approaches to engaging in treatment or not. Also adolescent brain development. So some research is suggesting that because the limbic system, the emotional regulation system, develops much faster than the cortex region of the brain, the reasoning systems, that can lead to increased risk-taking behaviors in youth, some of which are protective. They help us learn, they help youth learn. But especially when combined to the susceptibility to influence, that risk-taking behavior can lead youth to initiate drug use. And sometimes those drug use behaviors can be even more risky, just based on where the brain is at. In the research that I took a look at as well, some of the youth were surveyed about the effectiveness of abstinence-based education as the only option for conversation around drug use. And a lot of those youth felt that didn't actually match the reality of their experience. The Just Say No model, for example, really didn't recognize that there are drugs in youth communities, and because of brain development, because of all of these different factors, that it's really difficult for youth to just say no, that they're going to see drugs, that they might try to use drugs, and so that programming didn't feel as relevant or as effective for them. Again, this is not for all youth, right? Abstinence-only programming can be really effective for some youth, and in the research around harm reduction in youth, there is indication that having different types of educational programming would be really beneficial. Stigma and fear around drug use. It's pretty commonly known that there's a lot of stigma around illicit drug use, and especially for youth, when we think about the compounding stigma with their families, with their local community, punishment at school, punishment in the home. If the combination there can really impact youth ability to engage in services and care, because of a fear of punishment and fear of stigma. There are also resource barriers that exist in supporting youth who use drugs and accessing those traditional harm reduction resources. Many, if not all of them, are not available to people, especially folks under the age of 16. While there are some harm reduction services for transitional age youth, it can be really difficult to provide sterile syringes, sterile supplies to youth. And so there is kind of a dearth of youth-specific traditional harm reduction resources, so we have to get creative about the interventions we support. And then just kind of thinking around that stigma and fear. A lot of youth are still developing their trust in healthcare systems, their trust in their providers, And so that was cited as a reason why youth may not engage in care, particularly around their drug use from an early age. Population health data suggest that harm reduction strategies can be really beneficial for youth because unfortunately, in Oregon, we've seen a significant increase in fatal overdoses in adolescents over the past few years. In fact, the rate of fatal overdoses doubled between 2019 and 2020 for youth age 15 to 24, which is a really hard statistic to really take in. In addition, young people who use drugs are really overrepresented among new sexually transmitted infection cases. They represent over half of those new cases every year across the United States, which really suggests that education around sexual transmission infection, specifically for youth who use drugs, thinking about that HIV, that hepatitis C testing, gonorrhea, chlamydia, syphilis testing as well, as a way to engage with youth who use drugs is really important. So some interventions that are really exciting. There has been some school health curricula that is harm reduction based and that now has some evidence for effectiveness. The example that I'm going to use is this Safety First Real Drug Education for Teens. This was piloted with across 6 public high schools in New York and San Francisco, provided a harm reduction lens to drug education for teens. And the image that is here has some examples of the different types of content that that students can move through, thinking about just talking in depth about what drugs are, as well as harm reduction approaches to not just individual drug use, but drug use among communities of teens and among communities of youth, so more psychosocial topics. And the preliminary evidence around this curriculum in this pilot found that over the semester that this curriculum was given out, there was actually an increase in reporting about use, which is really, really critical. If we don't know our youth are using drugs, we can't support them. And because of stigma and fear, we don't always know. And so an increase in reporting is a really exciting data point to pay attention to. Also an increase in harm reduction knowledge, which is great. Glad to know that the education about harm reduction was effective. And especially including learning how to recognize overdose and how to respond to overdose among youth, which unfortunately, as we saw, is becoming more prevalent. And actually, this education curriculum demonstrated a significant decrease in reported use over the course of a term, which is pretty cool. It didn't, it's a point that this report made was that the education curriculum actually never talks about the need to decrease use, and so seeing that as an outcome is really interesting. All of this education material is free and publicly available through Stanford. I forget exactly which lab it is, but I'm more than happy to send it to folks who are interested. Also, just if you Google Safety First Real Drug Education for Teens, it's something that's available. I will say it seems like there is more data about that needs to be gathered about its effectiveness in non-public high schools, for example, in other contexts, but exciting preliminary results. And then thinking about peer support. So we were lucky enough to hear from local peer support experts this morning. There is data to suggest that peer-based interventions are really effective for youth. If youth have community of their peers who can talk about substance use, who can talk about different interventions together, that can be an incredibly protective factor against fatal overdose and even against sexually transmitted infection transmission. So some local resources that engage with youth, and by no means is this comprehensive, just a couple examples. The recovery-oriented supports and engagement, the ROSE program at Outside In, does a lot of outreach to youth who use drugs in our community to engage with folks through a harm reduction lens, to provide safer use supplies and really start having the conversations around what safer use can be in order to connect youth to more services. We also have NAYA, the Native American Youth and Family Center, which provides a range of services for youth who use drugs and their families through a culturally culturally specific and knowledgeable lens for Native American families and youth. And then, of course, 4D. Y'all heard from Tony this morning. Peer-based services for youth, helping youth on the path towards recovery. And then some national and international models. So for youth who may not have resources directly in their area through local nonprofits and services, Young People in Recovery is a great resource that really encompasses the widest spectrum possible of interventions for youth who use drugs to create that shared community across states and across jurisdictions. They have meetings online, they do events in local communities, and they're a really excellent resource. And then there's some really cool advocacy projects in Canada specifically, but also internationally with Youth Co. and Youth Rise that are really interesting to look in. Those are less about the practical strategy and intervention around harm reduction, but more around really bringing youth together to advocate and to share their voices for what they need in community. So a few lessons learned from the preliminary research into what harm reduction interventions can look like for youth. It's really important as we think about interventions for youth who use drugs to consider local and geographical and cultural relevance of any programming that we put forward for our youth. Also, youth have a lot of passion for advocating for themselves, as we know, across social justice movements, including for youth who use drugs. And so integrating youth perspective, youth voices into this programming is key, especially to ensure that it is relevant for them, it's driven by them, and the interventions will be effective. Ultimately, harm reduction messaging does really seem to resonate with youth. And so as we can have conversations that are non-judgmental, that encourage engagement with services, that encourage engagement with family, with community, with peers, that messaging can be really key as a protective factor, both to prevent or reduce drug use, or to really just meet the youth who are actively using where they need to be met. And then it's really key too to think about, because the traditional harm reduction resources and interventions aren't always available to youth, where we can leverage these interventions. So thinking about local health departments as a resource for low barrier screenings, for low barrier conversations, schools via the health curricula and others that I shared, and then the external peer agencies and others that I mentioned. That is my presentation for you all today. We have abundant time for questions and conversations if folks would like to dig in a little bit, and I really appreciate your time.
One of the questions I had was getting family buy-in to harm reduction, because I feel like so often what I bump up against is the, like, no, like, you need to stop, like, abstinence is, like, the only way. And so just curious if other folks or you yourself have, like, feedback or advice or sort of how to sell that to families of, like, this is actually an evidence-based practice and it can be helpful.
I'm going to look to any others in the room if you have thoughts before I share. Okay. My initial thoughts, because sometimes even just saying this is evidence-based isn't enough, right? It's so personal. It's so deeply impactful for parents, for other family members. And so I think the first step towards buy-in is just acknowledging and validating the fear, the pain, the anger, the frustration, whatever is coming up that prevents that buy-in. And that will look really different for different families. And I think trying to ground in the acknowledgement that whether they say stop or not, it's likely their kid is going to continue to use, or their sibling is going to continue to use, or their nephew, et cetera. Those two steps, I think, are the most important, first and foremost, to encourage that type of buy-in. A conversation takes a lot of work and a lot of time. Evidence can help, but I think that's the most important first step. Do other folks have thoughts?
Okay. I think that I try to help families like see the long game, right? So that it's going to be like kind of a longer process, and that really, especially with our youth who are using fentanyl and other like opiates, that the end game is to keep them alive, and that every time you use fentanyl, you are kind of trying to die. And so like just being like very upfront with that, and then how do we help reduce the chance that like this time is going to be the time that you die, so that way we can have like the time to get you in recovery, and then just do a lot of like supporting them, validating that like we know that it's hard, it's very painful to like go through, and we have to just start with them where they are, right? If they die tomorrow, then we don't have the chance to talk to them tomorrow about what's going on. And I think that that reality of it, and having someone to sit there with, you know, and just kind of, I feel like so often so many parents are pushing away that reality, you know, but to have somebody to sit there with them and then be like, okay, like this is where we're at, this is where we're going to go forward, I found has been really helpful.
Thank you for that.
Oh, sorry. If there's a resource, this is intimidating. If there's a resource that you could point us to, or if just people in the room want to talk about kind of the nitty gritty of what the actual strategies are we can share with youth and adults too, but just for risk reduction with different ways of using, because we're not just talking about fentanyl, and people have moved to more smoking rather than using syringes, but there's also other ways. There's all sorts of ways people are using different substances and stimulants and things. So I'm just wondering where I can get some good information that I can share.
Absolutely. The National Harm Reduction Coalition's website has a pretty robust list of fact sheets for every modality and every substance around how to why it's important to use sterile paraphernalia, sterile supplies when using, and how to reduce the risk if you don't have a lot of options. There's also a website that I think Yale put out. It's pretty highly medicalized, and so I'd proceed with caution and recognize the need to maybe translate those materials to a wider audience, but it does give kind of fact-based breakdowns of the risks of each type of mode of administration, and then ways to mitigate that risk. So I'm happy to send that to you or find it after the presentation so I can connect it to you directly.
Can you say the first website that you said?
Yeah, it's the National Harm Reduction Coalition.
Thank you. I just had a question about the Safety First health curriculum. I think I maybe misunderstood what you were saying about an increase in the research they did preliminarily showed an increase in self-reported use and then a decrease in maybe like population level use. So if you could maybe untangle that for me a little bit.
Yeah, absolutely. Thank you for requesting that clarification, because I think what they saw preliminarily does seem a little counterintuitive, right? There was an increase in reported use at the beginning, early in the curriculum, where as youth were becoming more comfortable talking about drugs in a harm reduction focused way, there was more self-report within the population overall. And then after the curriculum, they took a look and compared the data sets, and there was the same folks who reported use reported less use. And so it was less about an increase in prevalence and then a decrease in prevalence, but more we saw higher prevalence of self-reported use, and then that use decreased over time, either through cessation of use entirely or just less frequent use over the course of the curriculum.
Yeah, that's helpful.
Yeah, sorry that wasn't clear.
Hi, I'm having trouble with certain youth seeing the impacts of their addiction, even within harm reduction. So many of the youth I work with, even in criminal justice settings, don't notice the fact that their use is getting out of control or it's affecting their mental health symptoms. There's like a lot of like pre-contemplation there. So I'm wondering if there's more to help with that, because sometimes the literature doesn't seem to be enough to convince them, or just their personal stories.
Yeah, it's tough. It's really tough. I don't know if there is just a lot of literature out there around how to get youth, especially from pre-contemplation into contemplation for change. Everything that I've seen in the harm reduction literature around youth is really encouraged just continued kind, supportive, non-judgmental conversations, especially because I think there are heightened perceptions of judgment in youth from authority figures, et cetera, and just continued motivational interviewing, truly trying to get to understanding around what is driving the use, seeing if there is capacity to link the reasons for the use to the using behavior, suggesting alternatives, et cetera. But it's a tough one that I don't have a perfect answer to. I wish I did.
Next door, they're talking about that.
Great.
I think they're recording, so maybe.
I've heard the statistic a lot about the percentage increasing of youth death by overdose, but I don't ever see any numbers attached to it, and I'm just wondering if you happen to have that data point.
I don't have it directly right now, but I have exactly where I got that source, and I can see if it connects to actual numbers. Because percentages aren't always the most helpful. I know it was 6% of overdoses among that population in Oregon. The using population in Oregon increased to 12%. But again, no direct numbers yet, but I can find them for you after we're done.
I work at, I'm a youth alcohol and drug counselor at Oregon City High School. And our top three, cannabis, alcohol, nicotine. I'm not saying we don't see some of this at Northwest Family Services, where the agency where I work at. I know I've had counselors who have dealt with and are giving out Narcan, but I haven't yet at this point. And we use the term harm reduction. I mean, that's how we get. We have a captive audience, having them in school, which is great. What period do you want to miss? Come see me. There's a lot to get them into my office. I just, outside of, needle exchanges and all those things, which I think are awesome, I would love more ideas about harm reduction for those three things that are huge in the school community I work in.
Yeah.
I have some, but just other thoughts from people in the room. So,
Yeah, please. Any others, ideas, thoughts?
Do you want to share yours first?
Sure. Yeah.
I'd love to hear it.
Yeah. I mean, and it's more about getting them in the room, getting them buy-in. I know I'm loud, but getting them in the room, getting buy-in. I think the harm reduction idea of let's make your goals are your goals, and if it's to quit, that's great. We support that. If it's to cut down your use, that's great. So that harm reduction model, if they're using THC, let's use a lower percentage of THC, right? Let's talk about not bringing your THC pen to school. That's a form of harm reduction. And it feels like they buy into that, and then they leave services and they're still using and period. I don't know. It just feels like sometimes it's with how prevalent and how available, especially cannabis is in the community, adults around them using, how easy it is to access. harm reduction is kind of all we can do, which I'm okay with too. You know, I'm absolutely okay with that. But I just wondered if anyone has any other thoughts. And we give out gift cards.
I'm so glad that you brought up like alcohol use and cannabis, because I do feel like at least alcohol has like skyrocketed, especially over the last summer. Coming back, we have a ton more kids binge drinking. We had kids drinking at school last year and having to call the ambulance. Like, it was a whole thing. And so I think like that conversation, because we have been talking so much about fentanyl and other substances, kids are like, no, like, that's scary. I'm gonna go back to like the old school, right? Like how I grew up and like doing what I did. And so one of the things that I started doing with kids who do like habitually binge drink was talking about like the cycle that gets them there. Because, so I work as a family therapist in a high school in North Portland. And so many of the kids that I work with have trauma or anxiety or depression. And obviously community violence has been a huge factor for our population. So really talking about what is the function of the substance. Is it to reduce the discomfort and the symptoms you're feeling from mental health? And talking about how, like the cycle of abuse almost, like in relationships. What is the precipitating event that causes this rise in discomfort that makes you want to engage in that later? And then what is the consequential outcome of it, right? Because so many kids are coming in with like, oh, look at this like scrape on my knee because I fell when I was drunk. Or I got in a car with somebody who was drunk and driving and we got pulled over, because that happened a couple weeks ago. So I think like mapping out a cycle visually has been really helpful for some of my kids, because then they can see it. It's not just a conversation. And I'm a really visual person, so like I love my whiteboard in my office. It's just like the cheapest tool in my box. But I think giving folks a way to look at it can be a helpful way to see, oh, because my symptoms are increasing and I'm not taking my meds anymore. And then I had an argument with my partner or something, and then I was like, well, I'm going to go out drinking this weekend. That has been helpful. Obviously, not the fix. Yeah. Mm-hmm.
I love that. The only thing that I will add is that that educational curriculum that I mentioned also has alcohol, cannabis, and nicotine modalities, which is great. And I think one of the results that they saw was that engaging in those conversations around the curriculum created more supportive using communities, especially around alcohol, a little less so with cannabis and with nicotine, but creating communities of students to say, who do you use with, and how can you watch out for that person when you're all using together? Who do you want to watch out for you? So that can be a helpful kind of protective factor in acknowledging that the youth are using and they're probably going to go out and use again, but how do they keep one another safe in that context as well?
Yeah. Thank you.
Thank you. I just have a response to your initial thoughts. Do you have any ways of, robust tracking or data to know that maybe what you're doing in your harm reduction is working? Because it might be down the road and we don't know, right? Because the students move on or what have you. So that's kind of a question I had for you or for anyone else is, kind of measuring our progress with harm reduction.
I don't think we do. I mean, we work on, we have satisfaction surveys and, things like that. And I'm in the school where maybe I might see youth for 4 years if I see them in 9th grade, and then I check in with them and, and if they're doing great, like, we have that kind of information, but I think because I know 4 years is not a super short period of time, but it is, they're here and then they're gone and, they go off to college and you're like,
Yeah.
So that's a great question. I don't think we have that in my agency, so I'm gonna bring it up. It'd be good to know.
I mean, I haven't come across that kind of information either. Yeah. So I was curious if maybe providers or others in the room are aware of that, because, we're helping them build skills and having that self-reflection and thinking through that is helpful, even if we don't see it day 2 change their behavior.
or if they have a second or third episode,
Right.
you know, and you're bringing them back and you're like, okay, let's review what we did last time, and then, you know, what else can we do? How can we keep supporting you?
Yeah.
You know, that's, I mean, I love when they come back. Is that wrong to say? You know, like, I feel like, because I'm like, oh, I get another opportunity, you know,
Yeah.
to teach them something else, to build those skills, you know, and send them out in the world, you know, to be successful. So.
Absolutely.
Thank you. Just following up on that, I feel like the closest I've found is like external factors. So the youth find that their POs are off their backs or their school's performance is doing better. But I've found with my youth, they're still like, oh, I would have done that anyways. I'm just doing well. Yeah, like so we see a hard translation across like moving from outpatient into the community where they're no longer watched or they're no longer in a controlled environment.
I work for Portland Public Schools, as do these lovely colleagues on either side of me. And our data is very similar to Oregon City High Schools. Yeah. Like, seriously, 95% of our discipline data is for all the legal substances. And one of our data points, even though it's not as robust as we would like, is we have a leveled system for our discipline. And so what we look at the end of the year is how many kids got a level A, which is the first level of a drug or alcohol violation, and then a B, and then a C, like progress through the system. And I mean, our data looks okay. It looks pretty good, because what we do for the level A is similar to what you all are doing, and do 6 hours of psychoed. And that can happen in a class or with a CADC. And it does seem to, like, you know, if we have 450 kids that have level A's, then we have about 75 that have level B's, and then we have about 15 that have level C's. So getting the help along the way does seem to make a difference.
All right, that it?
All right. Thank you all for your, was that a question or just a? Yeah, please. We have time.
Communities, neighborhoods, and I'm just wondering, just other prevention partners, particularly in public health, and each county in Oregon funds alcohol and other drug primary prevention work in their counties, and I'm just curious about collaborations and connections there.
That's a really great thought. I will be honest, I'm not really sure about that, how that manifests, and as you know, like local health departments are a great resource to leverage in those partnerships. I'm just not really sure of the mechanics there. But do others have thoughts of how, like, examples, experience with how that has gone? Seems like we can do more.
Go ahead.
I've been taking up for you. I know. I'm taking up airtime. You go ahead.
So we all work at a community mental health agency. I think one of the things we started to talk about today is we are significantly lacking in specific addiction treatment for adolescents. So oftentimes we're in the situation where we have clients where we know that they need that treatment, but we can't get it for them. So then they're with us. And that is not like our area of specialty. And so I'm wondering if there's just any thoughts on, like, what are some of the main things that we need to be thinking about or that we can do in a setting that is not specialized but has clients that still have those needs.
My name is Kat. I
I'm at a community mental health agency and one of just a couple CADCs there, so I feel like this is the boat that I'm in very frequently. I think one of the biggest things that I have seen is talking to them about what substance use treatment can be, and understanding the full range. And we're seeing that today. So like you'll go away with that resource. But the amount of people who realize, if I agree to do a substance use assessment, I can decide what to do when I'm done. I can hear the recommendations and say, I'll take these two, but I'm not ready for those two. They can go into treatment and say, I want to reduce my weed use, but we're not going to stop it. Or I have been experimenting with fentanyl and I feel like that's pretty scary, but we're not touching the weed. So really, the amount of control that they have in what that substance use treatment looks like is wide. There's a wide range. And another area where I have found some leeway, I can't speak anymore. My brain is back from maternity leave recently, and that's what's happening. The amount of privacy that they get, that's another kind of helpful argument in like, this is something that we could look at. Let me tell you about the different privacies that are afforded to you when you're in substance use treatment. You get way more say even, than when you're a 14-plus-year-old in Oregon under mental health. We've got much more stringent privacy requirements. That can be really helpful in addressing that fear of like, well, what are my parents gonna hear from you about all of this? So that I think is a really good first step, just being able to talk to them about what is out there. Unfortunately, there's not enough agencies, as we're also hearing today. But just that openness, like getting them into maybe even that like contemplation stage of, okay, I'll see, what this assessment is.
I think the only component that I'll add is, in the moment, if you're working with folks, particularly folks who use fentanyl or who are concerned about other substances that may be contaminated with fentanyl, just some harm reduction best practices to share and to think about are encouraging folks not to use alone, which I recognize can be really complex for youth and even more complex for people with complex mental health conditions. And some of those best practices just to keep people safe and keep people alive. I've seen at least within our adult populations of integrated behavioral health with a focus on mental health disorders can be really helpful in just keeping folks there until perhaps that treatment resource is available.
I was just going to piggyback on what you mentioned. So acknowledging that not everyone is dual diagnosis providers, and sometimes we're just mental health. And kind of piggybacking on what somebody said earlier about exploring, like, why are they using the substance? What is that? What's the coping mechanism there? And really doing the mental health side of it, which will also have benefit on the substance use side of it. But just not feeling that pressure to like have to become a dual diagnosis therapist because you have somebody who's dual diagnosis.
I'm happy to stick around if folks want to continue the conversation, but I really appreciate your presence, sharing expertise, these really thoughtful questions, and of course, all the work you do. I also just want to shout out that there is a fuller conversation around harm reduction in Multnomah County right after the next break. So hopefully this has teed y'all up well for that. Thank you so much for your time and your presence.